it's a wicked communication problem. These two structural opportunities already create tremendous invisibility and challenges for the LGBTQ community to disclose this information, and also difficult for clinicians and healthcare professionals to have these questions to prompt them to ask.
Hello and welcome to Healthcare Strategies. I'm Shania Kennedy, Assistant Editor of Healthtech Analytics. Data on sexual orientation and gender identity is crucial to enhancing care for LGBTQIA+ patients, but this information is not routinely collected by healthcare providers, and it's missing in over 60% of adult electronic health records. Researchers and clinicians are calling for the collection of this data to reduce care disparities and improve outcomes for sexual and gender minority patients, but health systems must navigate long-standing challenges, such as biases against LGBTQIA+ people, to gather this information safely and respectfully. Carrie Kandrian, PhD, Associate Professor of Medicine at the University of Colorado School of Medicine and a 2024 Health and Aging Policy Fellow, is joining us on the show today to explore how healthcare organizations can work to improve their sexual orientation and gender identity data collection efforts. Carrie, thanks for coming on to the show today.
Thank you for having me.
Yeah, absolutely. So just to start us off, you have done some pretty extensive research in this area, but of course, when we're talking about data collection, especially in healthcare, talking about the why is the crux of the issue. And I know I teased in the intro that data on sexual orientation and gender identity isn't routinely collected in the healthcare system, at least in the US. So I was wondering if you could start us out by talking about what the implications of that are for care quality and access.
So in terms of the impacts, you mentioned it in your intro, but I really see it as there's a micro level and a macro level to really be able to see the consequences of not having concrete and accurate data about the LGBTQ community. I think on a very micro and individual level, the reality is that if people who identify as LGBTQ enter healthcare and they're not routinely and safely asked about their sexual orientation or gender identity, or they're not in an interaction where they actually feel safe enough to disclose this information, it can really lead to adverse effects. First, if you can't openly talk about or feel safe with whoever you're talking about to talk about some of your biggest concerns, chances are you're not going to really be able to give the full story, which means a lot of the healthcare team will be working with incomplete information, which means patients are going to be getting incomplete care. From a very practical level, how this actually continues to translate to concrete health effects is one example that I think is really hopefully easy for people to understand is a lot of people in the LGBTQ community are not married or haven't chosen to get married or have a partner that's not legally bound, which means that if, depending on where they're seeking care, if the question is, who's your family, and they default to a biological family, and the person doesn't feel safe enough to disclose who this person is, chances are they might not be allowed in the room to talk about treatment plans with their partner, for example. They may not be allowed to be in the room just to hold their partner's hand. And what often happens is the LGBTQ community experiences what is known as disenfranchised grief. So when a partner loses their loved one, if they're not known to the care team as a loving spouse, as a grieving spouse, they'll be referred to as simply the emergency contact or the good friend, which means they won't be offered grief support or bereavement support. And what this looks like is they'll have to actually deal with a loss of a loved one in total isolation, which can really lead to a ton of adverse effects down the road. And on the macro level, what this means is so if we're working with incomplete information on a very individual level when people are entering healthcare system, the result is in the vast majority of medical literature, LGBT people have been absent. So we're having these conversations about policies, about decisions with a huge part of the population being missing, which also means it makes it really hard to develop concrete strategies, concrete interventions, concrete ways to actually do something about the disparities that we know affect the LGBTQ community. So it has concrete effects. Not having SOGI data, sexual orientation and gender identity, has concrete effects on individual lives and also at a very macro system level that it's very hard to actually understand the outcomes and do something about the disparities given the fact that LGBTQ people remain so invisible.
And that invisibility is a key aspect when we're talking about this because as you mentioned, it's a complex problem because of course it's not just a question of are you collecting this data, it's how are you collecting it? What approaches are you using to create that sense of safety for your patients? And I think that's a hurdle that health systems are trying to navigate, but it's difficult. And you and others in the industry, other researchers, clinicians have been pushing to improve this data collection, but I'm wondering what are like some of the challenges that health systems face on that system level that prevent them from collecting that data?
They're enormous challenges, and I think it's a wicked communication problem. On a very like practical sort of system structural issue, we know the majority of our forms, like our intake questions, our intake questionnaires, they rarely have space or they rarely ask questions about sexual orientation and gender identity. So immediately, we often don't even have the space structurally to fill this information out or to disclose this at an intake. We also know that a lot of EMRs, electronic medical records, don't include these data fields as well. So these two like structural opportunities already create tremendous invisibility and challenges for the LGBTQ community to disclose this information, and also difficult for clinicians and healthcare professionals to have these questions to prompt them to ask. And then I think it gets really challenging because very little training, if healthcare systems do the work and create these fields, update their forms to ask these questions, and then have them in the EMRs. The challenges that we've seen is that very little training has accompanied these changes. And so they might have the space, but people underestimate how dangerous it still is to disclose this information. And so we've seen it in Colorado when these data fields have been added. Yes, we get decent data, but a lot of times we get things like patient refuses to answer or not applicable, which when we've looked at the data, doesn't actually come back to the patient. It often is because of a lot of uncomfortableness on both the person asking and the person telling. Because if they're not routinely trained or used to asking questions about sexual orientation and gender identity, it can feel really uncomfortable. And unfortunately, we haven't really normalized these like other race and ethnicity questions. And for the patient and caregiver answering these questions, if these questions are not asked in a way that the patients feel safe, that they feel like this information is being asked to provide better care and not being asked to be grounds for discrimination, it can create a lot of uncertainty on whether the patient should disclose this information. And so it becomes very complicated very quickly. And a lot of it is a result of communication, both the structural communication, that not even having the space, and then the awareness of how important it is to ask these questions in a way that people feel safe to disclose, and knowing that they might have to be asked multiple times, that this is not just a one-time chance, a one-time opportunity to ask this information. And so there's tremendous amounts of nuance. And I think that is also another challenge, is because of how complex these questions are. I think people think that they require too much work, or this is sensitive information or private. And if it's important for me to know, the patient will tell me, which just continues to perpetuate the silence around all this.
Absolutely. And that nuance is key here because with typical data collection, it's a question of, okay, how do we create the structure to collect that information? Like to your point, a lot of intake forms don't even have questions about sexual orientation or gender identity on them.
Mhm.
But then on the flip side, there's also creating that safety through training and through that normalization.
Mhm.
But of course, doing that is much more difficult. It's a little bit more nebulous. So, for health systems that are looking at that, looking at how to train their clinicians, looking at how to normalize these conversations and make their patients feel comfortable, what solutions or strategies can they start to pursue in that direction?
Unfortunately, there's not a lot. There's not a lot of great training available. SAGE, which is a tremendous organization that does advocacy for older LGBTQ people, they have a training program, but it's really more on like, how do you care, which is terrific. How do you care for LGBTQ people? And SOGI is one piece of it. But this is a huge gap that we aren't prepared to fill. People who are willing to do this, people wanting to do this better. We don't have a lot of great training. But I think there are some things that people can do immediately, and really underscoring that a lot of it does come down to safety, and now more than ever, really depending on where you live, where you're getting care. The safety kit, I don't think I can underscore how important the safety is. And so I think for organizations and some of the stuff that SAGE promotes, and what I've been looking at with the hospice study that I've been doing around SOGI, is really going out of your way to make it clear that you're safe. Whether on an individual level, it's wearing a pride pin, a rainbow pin, a trans pin, any sort of sign or symbol you can wear that is visible to people, because we look for these. And especially when we're entering healthcare, we look for any sort of subtle sign to know that someone is okay with us, that we can be open about who we are and who we love. So I think a very practical signs and symbols go a really long way for the LGBTQ community. I think on a more organizational level, the materials, again, if there's a non-discrimination policy, as soon as you open up a brochure, for example, or a couple with two lesbians, these go a really long way in communicating that, again, you're an organization that's not going to tolerate inequity, and you're an organization that actually wants to know all of you and really embraces all of you. So those two things I think are from an organizational, both marketing, website, materials, and then a very practical way of showing that you're an ally or part of the community, whatever you feel comfortable with sharing. These signs and symbols do tremendous amounts of work to really open the pathway to having a better conversation.
Yeah, I think that emphasis on community and creating a space where people can build community, because, of course, your healthcare organization is part of your community. Hopefully, your providers and your healthcare professionals are part of your community. And of course, this all it's very nuanced, and it is really on health systems to say, okay, we are going to prioritize this and we are going to work to make these changes. But as they do that, getting back to speaking more about the data piece, when you're collecting these data, when you're analyzing these data, especially to improve health equity, which is the point of efforts like these,
Mhm.
there's the question of how do you assess improvement in care? How do you assess that care disparities are being reduced? So that's something that I was thinking about as I was reading your research. Once a health system is collecting this information and working to ensure that they're doing so in a way that's complete and respectful and safe, how do they measure improvements in their data collection and their care?
That's a really great question. Getting the data is the first part, obviously, as you mentioned. And I think then being able to, and it's a great point of, I think people, now that we have the data, which we really don't have the data, what do we do with it now? But to actually begin to utilize it. And so I think that really putting pressure on like these national registries to share these data and have it be included would be a great first step to actually make sure that LGBTQ people are part of these larger registries that are shaping a lot of policy. And I think building in the need to begin to analyze this. Are we able to get this information? Being able to start evaluating trends. I think all those are really great things. We're starting to get the data. And I think that what we need now is to really have messaging from like more federal organizations that are really wanting to include some SOGI data to really begin to analyze these broader trends.
It's really it's a tough issue, and that's why I wanted to talk about it, because
Mhm.
of course, like we talked about, this is not just a question of collecting information, it's how do we bring people to the table? How do we get stakeholders on board, and how do we do that in a way that works for everyone? Because, of course, bias and discrimination is a real concern. And so just Having these conversations, I think, is one way to raise that awareness and get people in the industry talking and thinking about, okay, how do we address this and how do we make sure that the people who need to be at the table are,
Yeah.
because for so long they haven't been.
Yeah. And I think too, this also it might be related. Really having making it clear that for a while too, we're still researchers like have not included LGBTQ people or have not included it as a demographic. So a lot of that same literature, not just from like an EMR perspective, but actual researchers and national surveys not including LGBTQ people. So I think that's another area where I really tried to like demand or really put pressure on other researchers to include LGBTQ people in their studies. And I think that can begin to shift the narrative, at least our understanding of how all this affects LGBTQ people, how cancer outcomes, diabetes, cardiovascular health. We know it at least enough from the data that they do disproportionately affect LGBTQ people. But to actually make sure these large NIH studies, these large federal funded grants are also including LGBTQ people is a really important, I think, thing, especially going forward. To read a study, to look at the demographics and not actually see sexual orientation, gender identity is really inexcusable. NIH is doing a great job of encouraging this information. And that's where we're already starting to see studies on how do people want to be asked these questions? When do they want to be asked? And I think all those are great trends to really help other people, one, realize why these data are so critical, and two, what works. A lot of the recommendations we have have been tested like in the emergency department or primary care or among younger generations, very little among older adults. And so I think that there's just tremendous amounts of opportunities to do really great work in this area with the hope of, well, not with the hope, with the expectation that it's going to help others feel more comfortable asking these questions and executives to really make sure that this is going to be part of the healthcare culture that they are building.
I completely agree. I think creating not just a hope, but an expectation
Yeah.
that this data will be collected and that people will be asked these questions is huge.
Mm-hmm.
And that's something that has to be prioritized in the name of health equity. If you're a health
Yes.
system that's committed to health equity, this is something that you're probably already thinking about. But if not, this is why. That's why we're here. That's why we're talking about this. And this is such a fascinating topic, and it doesn't get talked about enough. So I just want to thank you again for coming on to chat with us. It's really great that people are doing research to raise awareness and say, here are the issues and here's how we fix them.
I really appreciate you having me and keeping this conversation going. Can I add one thing to one earlier question you asked me?
Absolutely.
About what people can do, particularly from the training perspective. And that's something we're trying to do with the hospice. But part of why I got into all this was I'm not a clinician. I have a PhD in communication. And why I got into it was really I saw the concrete effects that the way people were talking and listening were having on people at the end of life, and particularly people who had been historically stigmatized and trained to stay quiet. And so I think to really also underscore how important people's own communication is around all this in terms of how some of these common scripts that we're so used to asking can be really detrimental and shut LGBTQ people out really quickly. Like the old, are you married? Are you a man or a woman? These binary, outdated scripts, particularly I think for the older generation, but probably across the lifespan, how important it is to really open up our questions in ways that people can feel like they can answer in a way that actually fits them. And I think one of the things we've seen around SOGI that's a pushback is people who don't identify as the LGBTQ people wonder why they're being asked these questions or sometimes even being offended. And I think the thing with these questions are what I've called like breaking the script. Who's the biggest support in your life? Do you live with anyone? Who needs to be in the room? Who do you consider family? These are questions that anyone can answer, whether you're part of the community or not. And what I think the advantage is that we're going to get better information. And I think that's also going to be able to build rapport and trust that then makes asking these demographic questions a lot easier.
Yeah, absolutely. The trust building is so critical.
Yeah.
And of course, there is no here's how to build trust with your patients handbook. If there was, there would be less issues like this, I think. But just creating that space for dialogue and, like you said, breaking the script, reframing those questions, invite people to share in a way that feels both safe and authentic for them, like you said, whether they're part of the community or not. That is all the time that we have. So, Carrie, thank you so much again. This was a wonderful conversation. It was really fun.
No, thank you very much. Yeah, I really enjoyed it. And I really enjoyed this work and the questions and just the opportunity to talk about these things in the face of health equity. I really appreciate you having me.
And thank you, listener, for tuning in. If you liked what you heard, head over to Spotify or Apple and drop us a review. We will be choosing some of our reviews to be read on the show in appreciation, so keep listening through to the end because you might get name dropped. See you next time. Music by Vice President of Editorial Kyle Murphy and production by me, Kelsey Waddell. This is a Tech Target production.